Welcome to Cardiac MR Simplified at MRIcardiac.com. I am Dr. Bhavin Jankaria. It's my turn today. And let me wish you a lovely 2025. And let's move on to the case. It's the 177th. That means we've been now doing this for more than uh, 3 years. And all credit to Dr. Priya Chudkar for doing this. I do it once a month. She does it the rest of the weeks, and it's just amazing uh, how she's able to do this week after week, every Thursday. All right. So the topic is fish mouth and hockey stick. This is a 40-year-old patient who had a lower respiratory tract infection. A routine echo showed severe MS, completely undiagnosed before that. And on the echo, there were quite, typical findings. Now, if you look at the MR here, there's normal contractility and thickening on the short axis, two-chamber and four-chamber as far as the LV is concerned, but clearly the LA is dilated, and we're seeing some issues with the mitral valve. The multiparametric is completely normal. So if you just look at the findings here, there's normal LV and RV function. There was elevated LV wall mass and end systolic volume. LA is dilated. There's something wrong with the mitral valve. There's normal T1, T2 stir, and no late CAD enhancement. Now, if you look at the mitral valve area, you can clearly see that there's restricted opening and mitral stenosis. There is mitral regurgitation here. When we measured, the fraction was about 39%. So if you now add these on, and I've just changed the order here, you have an abnormal mitral valve with 39% regurgitant fraction. Now, we can't really do velocity measurements for the mitral valve with phase contrast imaging. The values are usually erroneous. So what we can do is planimetry. And clearly, with an area of 1.4 square centimeters, this is abnormal and suggestive of severe mitral stenosis. And so there was discordance with the echo finding, which was 1.1 square centimeters. And this is something that has been described as well. But more importantly, if you look at the mitral valve, that's the maximum valve opening, and we've got clearly significant thickening along the commissural margins here, and that gives rise to this fish mouth appearance if you kind of take it from here to here. And the anterior mitral valve leaflet, the A1 scallop, shows a hockey stick appearance. So if you add that in, you've got an abnormal mitral valve with fish mouth and hockey stick signs. And just to give you an example of what a normal mitral valve, when it's completely open, looks like, the commissures, reach the edges of the AV junction and the annulus here, whereas they don't in this particular setting. And then I pulled out two other patients, and that's your normal patient. That's the index patient we are describing. Another patient here also shows a lot of low signal, probably because of calcification. I don't have a CT here. And this one is milder, but again, see the irregular shape of the mitral valve in the restricted opening here. And if you want to see the cines of these, they're just really amazing, rather even beautiful, if you wanted to say that, in terms of what is happening to the mitral valve here. Let's look at the hockey stick appearance, and that's your normal patient, where often in normal situations, the mitral valve leaflets are often blurry. You don't see them that well because they're not fixed, they're moving all the time. Whereas here, patient two, you don't see a classic hockey stick because you've got all this low signal, probably from the calcification. But the third patient with the milder disease again has this hockey stick appearance. And you can see that on the cines. It's very interesting how you have these abnormal chordae um, attached here. And you can see that well. There's another thing that's happening here, if you see this very well, and that's the uh, prolapse of the scallop into the left atrium. And you can see that here. This is the normal patient. That's a Miles collapse. That's prolapse, not scol. I just made a new word. Scallop and prolapse equal to scolapse. All right, so that's a prolapse. So there is a whole thing about prolapse, billowing, flail. And that's something I don't think we've ever addressed at MRIcardiac.com. So I'm going to keep my eyes out for this, and maybe in the next two or three ones, I'm going to do an entire post on the mitral valve with the A1, A2, A3, P1, P2, P3 scallops, and then all of this stuff about, while we've already done restricted opening, I think we should also look at that part of the pathology. So here you can see how it's prolapsed, and in fact, you'll see that even the point, the coaptation point is kind of almost into the left atrium or at the level of the annulus, and this is very mild here. This is rheumatic heart disease. And and I'm sure you made that out already. Uh, and it's a disease of the poor, a significant public health burden. And I think it's important to know this. It's responsible for almost 150,000 deaths per year across all ages. That's the prevalence. That's huge, right? It's like 1 in 300 in the 5 to 14 years age group. And if you look at this, this is clinical prevalence, right? So you're looking at almost 3.5 per 500 people having some form of rheumatic heart disease, which basically means that the prevalence is far more than any other cardiac disease except ischemic heart disease and hypertensive heart disease. And yet, I don't remember a single conference where anyone's given a talk or spoken about MR and rheumatic heart disease. And that's uh, and it is the commonest cause of valvular heart disease. So there's been this nice article that came out in 2023 in EHA Open, which then talks about rheumatic heart disease. And we all know from our MBBS days, it's acute rheumatic fever, strep A, and then there's an autoimmune response to the carditis or causing a carditis, which is both myocarditis and valvitis, if that's a word you'd want to use. And then when the inflammation subsides. The myocardial sequelae are minimal, but you do have sequelae in the valves causing stenosis and regurgitation. The mitral valve is the most commonly involved, and then you have atrial fibrillation, stroke, endocarditis failure in if the as a person ages. Everything's on 2D echo, right? Diagnosis, characterization, follow-up, post-op management, prognostication, and which is why we don't pretty much do MR or have known MR. But let's face it, we're all students of Western so-called modern medicine, and we therefore follow, cardiac MR is something that you learn in a Western world, and then kind of come to India and implement. I did that as well. And so you basically focus on the Western diseases. And so it's always ischemic heart disease, hypertrophic cardiomyopathy, all the myocarditis now that we're looking at. And now the new buzzword of genetic cardiomyopathy. But rheumatic heart disease, I mean, this is the single largest group of diseases that affects the heart outside of ischemic and hypertensive heart disease, and we don't know anything about it, right? There's one paper from India, which was again part of this three country series, which only talked about volumes, etc., didn't talk about what the mitral valve looks like. Why is this important? So, if you look at the World Heart Foundation criteria on echo and screening for rheumatic heart disease, they pick up 20 times more people than the ones who are diagnosed clinically. 20 times. It's insane. Which means there's a whole group of subclinical rheumatic MS patients and rheumatic heart disease who present with other things, right? You live long enough, you'll have ischemic heart disease, perhaps even hypertrophic cardiomyopathy, perhaps other things. And the MS or whatever rheumatic heart disease of the other valves is picked up incidentally. They've just lived their lives like this. And I'm going to do a whole series now. So Next month, I'll look at all the other issues with rheumatic heart disease, and then we'll focus on the mitral valve as well. So look at this 67-year-old presents with VPCs. An echo obviously was done, shows signs of subclinical rheumatic MS. You can see the LA is dilated. There's restricted opening of the mitral valve. And if you look carefully, you actually see a hockey stick sign. You see this abnormal configuration of the papillary muscles and the chordae tendineae. Obviously, all of this is normal. And then here's your fish mouth, right? Restricted opening. You can see the tethering here where the commissures are thickened, and you see the hockey stick sign of the A1 scallop. And that's classic MS. And it's something that we as radiologists doing MR need to be recognizing. That's the cine of the same patient. Here you can see there's a little bit of MR as well. And it's possible that the VPCs are part of the MS itself. You live long enough, then, all of this is likely to happen. And perhaps, I didn't look for MAD at that time. We didn't have additional sequences. Maybe that was there as well. So there are other roles. So these are all the indications for CMR and rheumatic heart disease summarized in that same article I talked about. And there's more as well because you have complications and other heart disease, etc. And this is the post I'm going to do next month as well. And I was going through my archives, and we have at least about 20 odd patients of MS or rheumatic heart disease that we've scanned for a variety of reasons. Many of them post valvuloplasty, but that's fine. We just look at them as well. So just please understand, given the burden of rheumatic heart disease in India, it's not uncommon to see patients with subclinical MS presenting often for other reasons, right? And even if the patient has an infarct and has come for viability imaging, you do need to report the findings. You can't say that, oh, echoes shown it, so it's not our responsibility. And so most of the findings described on echo are appreciated on MR, and therefore we should just know what they look like. That's my WhatsApp channel. That's the book that started it all. That's my new book here. And thank you so much for listening to me. Have a great year ahead.